Thank you, Achilles, for your excellent words. I would like to thank the Organotic Committee and especially Kostas Parias and Patakos for the invitation. Let's move to the case. No disclosures. The case is a 85 years old male. It has a history of AVR 7 years ago with a trifecta 21, and it was presented to our center because of exertion dyspnea that was exacerbated the last 2 or 3 months. There isn't any other comorbidities except hypertension. The cardiac echo revealed severe AR with a good injection fraction. And as we know, trifecta is a valve that has withdrawn now because of the early degenerations. And as you can see, this study, almost at the fifth year, the degenerated has started, and except the early degeneration, this valve is associated with increased mortality. That's why we should act soon, and the coronary angiography revealed no significant stenosis in the left artery. The right artery, there was a difficulty to engage the ostium, and you will see in the following slides why. Nevertheless, there wasn't significant stenosis in the right coronary artery. The risk is high. According to the guidelines, the TAVI was the choice, but we have now enough data in the literature that the TAVI is also a good choice for the rest of patients except the high-risk patients, with good results, especially good late results. There is a meta-analysis of 16 studies that show us that valve it's almost a comparable choice regarding the redo SARV. Let's return to the case. Trifecta has our valve trifecta 21 has 19 only internal diameter. It also confirmed in our orthography and analysis with the trimensio. You can see the diameter. Fortunately, the cusps isn't also small, but the problem was the height of the right and the left coronary artery. It was below 10. The problem was especially in the right coronary artery because there was the distance between the right ostium and the valve was only 3.5. This was the explanation for not engagement of the right coronary artery. There wasn't enough space between the valve and the aortic wall. According to the studies, we need to protect the right coronary artery. Of course, there are, except Basilica, there is also the Gymni technique. There isn't issues from the from the legs, so let's proceed. We advance a wire in the right coronary. Also, we choose a balloon expandable supraannular valve in order to avoid more reduction of the diameter of the trifecta valve. After deploy the valve, we pull the stent above the level of the trifecta, and we inflate the stent with excellent result. This is the echo 1 month later, good LV function, and the mean gradient was 15. There isn't any AR. And thank you. This is our team in our hospital.
Very good case, Fotis. One quick comment. I think it's very important to keep in mind that as things will progress, we're going to be dealing with more and more calcified and bulky leaflets, especially when we move into the TAVI scenario, which is not the case here, however. Having that said, I think that what we saw yesterday and our experience is that protecting the coronary ostia with a similar technique is as efficient as doing any other leaflet modification procedures. So that saves time and money in some cases. Any questions from the panel or from the floor? Comments? Okay, so let's move on because we're having a